Welcome to Take 3 and Call Me in the Morning, a podcast where three doctors from three different disciplines cut through the noise and bring nuance and practical insight to conversations about health that actually matter in our day-to-day lives. I'm Vahid, a physician, and I'm joined by Pega, a doctor of clinical psychology, and Adam, a doctor of physical therapy. We bring our perspectives together to connect the dots and tackle the questions, trends, and everyday issues that can leave people unsure of what to believe or what to do next. No gimmicks, no fads, just real conversations grounded in evidence, experience, and a dose of common sense. In today's episode, we pick Adam's brain with regards to the complexities of spine health. We talk about the importance of education, prevention strategies, the role of core stability in maintaining spinal health. Pega shares her own experience with back pain and back surgery. And in this discussion, we'll also touch on the significance of patient perspectives in healthcare and the ethical responsibilities of providers. We hope you enjoy. All right, we're recording.
Hello, team. We are going to discuss some spine things today. This is going to be a little bit more free-flowing, discussion-based. I know I have all kinds of stuff to speak on regarding spine. I know you guys have had some personal experiences and would love to hear about that. So I'm going to open up the floor to you guys if you guys want to direct any spine-related questions to me, and we can kind of kick off the conversation that way.
Great. I'll just jump right in.
Do it.
Hey, Adam. Hey, Vahid.
But you haven't been jumping because your old back hurts.
Well, yeah, that's true. I do not do the box jump. That's something I refuse to do in a gym class.
Because they're terrifying and they're going to eat your shins?
Yes.
Yeah.
And maybe break my back. So the reason why this is so personal to me is that in 2015, I actually had back surgery. I had a micro discectomy on my L5-S1. Is that right, Adam? Vertebral disc.
Did I get it all right? Vertebral disc. Yeah.
Nice. I didn't know how to say that. All right. Yeah. So I did that. Yeah. And ever since, I think I realized I've been on this journey, and I've realized how much of me neglecting my well-being contributed, I think, to this disc degeneration that occurred in my spine. That I feel like it's an important conversation for all three of us if we were to sort of approach the spine from our own areas of expertise, whether it's the psychological and the, sort of the lifestyle overall, and then the physiotherapeutic. So I don't know that I have a question, but I do know that I have an investment in it.
Yeah, that's a good starting point. And I, as a physical therapist, I'm going to take more of a structural, musculoskeletal, neuromuscular approach to it. I think a good starting point would be to explain a little bit to the audience what you just said. I know I am going to go off on major tangents here, so I really need you guys to jump in there and tell me to shut the hell up and move on to the next subject. Deal?
I'm good at that. Yeah.
Deal.
All right. Are you guys ready for me to bust out the spine model?
Let's do it.
I knew that's what he was going to do.
Yeah.
There it is.
He just wanted to show us his shorts.
Show me your jelly donut.
The jelly donut. Oh, the jelly donut. I marked it up. I marked it up already. So this is a
nice,
a quite old diagram. What do you call these? I guess model. I don't know. Anyways, what Pega was discussing, we'll see if I can get this in the camera here, is a intervertebral disc that was probably bulging or herniated, and I assume impinging on a nerve, creating maybe leg pain. So I won't go into, I'll try to not go too crazy into this, but
I might get PTSD from it, just so you know.
Oh, well, you let me know. Trigger warning? Should we have a trigger warning on this? Trigger warning for back pain?
I know a girl. If you have PTSD, I guess she can help you out.
I'm right here. Here's how EMDR fits right into the equation.
It all, time is a flat circle, as we say, right? So we have our spine. This is our lumbar spine. We have 5 vertebral bodies here. In between those, we have little shock absorbers called the intervertebral discs. So when we're talking about a segment, we always describe it as from the point of view of the intervertebral disc, right? So this would be L5S1 disc, right? So in the back, this is the front, this is the back with the little tails. Behind the disc, we have the nerve roots exiting out left and right, and the spinal cord in the middle. Generally, when you have a disc that is bulging, it's usually going backwards, and it's often going off to one side because we have a big, thick ligament going right back down posterior to the discs that prevents it from shooting right into the spinal canal. You would get different symptoms if it was a central compression versus a nerve root compression. So you probably had a nerve root compression. It was probably one-sided, definitely leg pain, maybe some reflex and motor loss. Yes. I don't know. Did you have any? You did have that. So there's the disc.
Not motor loss, but I've heard of people having, what is it called? Where your foot drop. I didn't quite get to foot drop. I know that.
Okay. Yeah, and that would be a tibialis anterior weakness. So that's L5S1 nerve root areas. But with the disc, you have an inner part. We call that the nucleus. It's about 90% water. It's kind of more of a little bit more viscous than water, but you can think of it kind of as a watery material. And then we have 25-ish layers of concentric rings that's basically like a ligament encircling it. So if you like chopped a tree down, remember when we were kids, we could count how old the tree is.
I'm kind of have something. Deep breaths right now.
Are you triggered by the tree cutting?
Yes.
Oh no!
Considering what a microdiscectomy is, it sounds like.
Oh, it's not that bad. It's not that bad. I'm just getting to where it will make sense.
Okay, I'll stop interrupting.
So, well, okay. I need to be cautious. I need to be gentle with Pega's feelings here. So, short story is that nucleus portion can, because of pressure changes, can be pushed out in one direction or multiple directions. In your case, probably one direction. What leg was it? Right or left leg?
Left.
So yeah, posterior lateral to the left. So it can bulge everything out. It can tear through the annulus. By the way, that's what the concentric rings are called, the annular fibers. But a quick kind of short-term treatment for that is going in there and shaving off that herniated or that bulged part. Often they'll also burr out the foramen, make that opening a little bit wider, so that that's a laminectomy, so that the nerve can have more space. It's everything is really a spacing issue when we're dealing with the spine. What is potentially problematic with that is we want stability in the spine. Its sole purpose in life, other than housing the spinal cord, is to provide stability, support, and basically a bridge or a force transfer, right? So we want stiffness, we want stability. When you are cutting away part of that structure, you are making it inherently less stable. Yes, there's a reason to do it. If a nerve is compressed for too long and you start getting muscle loss, there's a time constraint, right? That then you can get into the chronic radiculopathy, which the nerve is just not going to heal, even if the pressure is reduced. So definitely can be a good option, but any of these, and with most, especially more invasive procedures, there's always a cost benefit analysis there, right? So you personally would just want to really make sure that you are well aware of how the spine works, the positions, posture a little bit less, but how to engage the spine well, how to exercise and move well in a manner that's not putting you more at risk for a re-herniation.
Can I interject here?
Yeah, hop in there.
Yeah, so let's stick with the same example here. What typically leads to that? Like what are the, I know it's probably several things, but what would be like the most common cause or common causes?
Yeah, demons.
That's what demons. I thought it was.
Okay. Yeah,
demons. I told my parents I blame them.
Yeah, what is it? Incubi, succubi? Yeah. So most of them that I've seen are repetitive over time type of things, like little things over time, wear and tear here and there, and then they just meet some sort of threshold and they give way. Obviously, you can have traumatic injuries, car accidents, falls, whatever. But especially when you start getting into mid 20s and later, it's usually repetitive overuse types of injuries. That can then filter out into a number of different things, from body weight to body type to genetics, all of the other health and wellness concerns that we talk about: sleep positions, right? Exercise, movement, hydration, right? Remember, this is 90% water, all kinds of things. So it's tough to say, to point to one specific thing. I even hesitate to talk about the movements behind it, because people generally internalize that as, oh, don't bend over because you're going to herniate a disc. Um, so I'm not going to talk about it.
Okay. So, all right. Then thank you for that. That makes sense. What I want to ask is, then does it become a situation much like a lot of what we talk about, where obviously prevention is going to be, a lot more effective? What could we be doing to prevent that type of injury, that type of lesion?
Yeah, we don't have good evidence pointing to any one thing that's the end all be all of prevention. Prevention is great, but it's going to take more of a global health and wellness approach than a specific core approach. Um, there are any number of ways. Let me track back a little bit. I would, if gun to my head, I would have to say education would be the best prevention, hands down, right? Understanding what your spine is, what it does, the tissues it's made up of, and how it works is, in my opinion, the most important thing. That's day one, hour one of me working with almost every single patient that comes through here, is explaining that. And the basics of my explanation is, what is the core? Well, it's this cylinder. We want to provide stiffness. We want to be able to achieve stiffness. In order to do that, we have to turn on all of the tissues around it, right? The diaphragm at the top, the pelvic floor muscles at the bottom, and then the 4 to 5 layers, depending on what you consider a layer, of muscle tissue that forms the side. So think of a Coke can. If you try to crush a Coke can that when it's closed, it's pretty tough. If you pop the top open, way easier. So the external pressure can easily overcome internal pressure if one of those three segments is not functioning properly. You follow? So the core, in terms of a biomechanics property, is really just a force transfer mechanism. We get lots of force from the big muscle groups of our legs. Remember, force in musculoskeletal anatomy world is defined as cross-sectional area, so the volume of a muscle. These core muscles are very paper thin. They don't provide a lot of force. People often think, oh, I got to strengthen my core so I can get more power for my golf swing or whatever. That's not really the case. It's more control and more stiffness, so that you can transfer more efficiently that force from your leg muscles up through the core and then through your arms or whatever. A good example of this is, if you're familiar with weightlifting, a back squat, a barbell back squat, and a leg press machine. Have you both done both of those, or
Yeah.
seen them at least? Mm-hmm. In theory, if you had 100% efficiency of core tension, you would be able to back squat close to what you can leg press. And we all know those are very different numbers if you've ever used any of those implements to work out. But with the leg press, you have 100% efficiency because you're pushing up against a stable surface. We cannot even achieve 100% muscle contraction on our own. We need outside electrical stimulation to do that. But I like to kind of use that analogy to drive home the point that it's a force transfer or a bridge mechanism.
That makes sense. I like how you put that. Like, I could visualize it. I fully understood what you're saying. Okay, so going with, are you comfortable talking about your case, Pega?
My case?
Yeah, like if we continue down that path, would that be okay with you?
That's fine if that's okay with you guys.
Yeah, I was, because it's always easier if we have like a specific situation to sort
And
of to.
I mean, and I can share so much about what maybe I understand might have been the little causes over time and my own stressors. And I mean,
Yeah, talk about those. Let's see if they reflect to things that I would accept as
yeah,
reasons for
yeah.
why that might have happened.
I will say the literal straw that broke the Pega's back was the bar squat.
But yeah,
Interesting. Okay.
I had already had some damage by I was lifting boxes and moving from one office to another. Interesting that I just did that this week. But I was lifting a box of books and I had the wrong shoes on and I t- t- tilted or twisted my spine a bit and it triggered a bit of a herniation. That was actually June 9th, 2014. And then for until January 5th, 2015, I was going to PT. I was trying what I could at home. It really wasn't getting me far. And finally, I was working with a personal trainer at a gym. And I wasn't quite at the time available enough to myself to say, when he asked me to squat, I did say, I really have to be careful with this. I just intuitively knew I wasn't strong enough. He's like, no, no, you can do it. You can do it. You can do it. So I went down and it just popped. January 5th, 2015 was the day that basically I became immobile. And then April 20th, 2015 was my surgery date.
now let me ask you this: going through some of that initial rehab and stuff, did what I just say resonate with you at all? Had you heard anything about how the core is supposed to function or the anatomy of the discs or anything?
No, no, all of that
Yeah.
was, I mean, even in PT, they weren't
That's
meaning
what
physical therapy.
that's what I'm talking about. It is of my personal opinion that 80% of the successful intervention for back pain or spinal pain is educating the patient. So, anyways, just curious to hear your experiences with that. So squatting especially, you can get what is called the butt wink. Depending on if you go too low, then your pelvis basically starts to tip forwards,
Yeah.
or well, technically it's a posterior pelvic tilt. But think of the disc like a jelly donut. If you put pressure on the front of the disc, whereas that jelly is squirting,
Out.
out the back. Yep. So that's kind of a very simplified view of the disc dynamics, but that sounds accurate. Yep. That sounds like something that
So
would cause that pain. And then, did you have immediate pain? Here's another interesting thing that people always, or did it come later, a couple hours later, or the
I mean,
next
from
day?
what I remember, I was furious with this guy, and I was like, I don't think you should ever talk to me again. And
That's
I'm out
fair.
of here. And
That's
I went
fair.
home, and yeah, it was pretty. That day was that's why it's in my head. Like that day, it was a pretty bad day, and from then on, it just never got any
Yeah,
better.
it tends to build.
Yeah,
What I've heard is, yeah, somebody might have a pop or feel some sort of mechanical symptomology, and then the pain starts to build, right? And we can go into the different pain fibers like C fibers and A fibers, but we're not going to do that, guys, because this
yeah,
is
because I think my heart rate's
I,
gonna go through the roof.
I'm curious, that if a case like that were to enter your office right now, Adam, like where would you start with that? And you could choose to say, okay, this is right after surgery, or maybe before, when they're deciding whether or not to do surgery. You could pick whatever point you want, but I would say just walk, if you don't mind, walk me through, or walk us through what that looks like, and what are the things that are being addressed, and sort of.
yeah, great question. I'm going to choose before surgery because I have failed if I am seeing somebody after surgery that I also saw them before surgery for the most part. Um, Nobody's batting 1,000, right? Uh, yeah. So I always talk about phases. Maybe you guys have heard me talk about phases, but I like to break it down into phases for patients. So phase 1 is control pain and inflammation, right? We have a hot disc, as some people call it. We need to, one, understand the underlying basis for why that pain is there, make sure it's a disc, right? Rule out any, our differential diagnosis techniques. And then start to calm that down. There's a number of ways to do that. There's all sorts of different schools of thought around that. From McKenzie is the big one. That's kind of directional preference based.
I really love what McKenzie did for me.
Yeah. People are going to kill me, but I'm blanking on all the other schools of thought. I just kind of use take a little bit of everybody, use what works and throw out the rest. So yeah, probably I'd want to get some blood flow there. So whether that's dry needling, soft tissue, mobilizations, whatever the case may be, heat, right? I want the tissues well perfused, right? Vasodilation is another way to think about that. I want to then start loosening up the tissue layers, right? The skin, subcutaneous fat, fascia, muscle tissues, and most importantly, the nerve. We have things that are called nerve glides or nerve flossing. So you're basically moving that nerve tissue so it can get unstuck, for a simple way to think about it. And then some slow, gentle stretching to get all of the surrounding tissues moving, especially the hips, maybe some of the thoracic stuff. But phase 1, reduce pain, try to improve motion, blood flow. That's kind of an easy way to think about that. And then once you've hopefully started to see some centralization, if the pain's radiating down the leg, you'll see it start to creep back up towards the source or the point of origin, which is hopefully the lower back, if we've diagnosed this correctly. And then you can really start to hit home with strengthening around that, doing some functional movement patterns. But to answer your question, yeah, control the pain, improve blood flow.
How long does phase 1 typically range? Like, I know it's different in every case probably, but what would that look like?
Let's see. There's a huge difference if I can see somebody within the first 72 hours after a initial injury or an exacerbation. I truly feel if I can get in there within 72 hours, I'll have that calm down in a week or less. And it does seem like any time under that, it's a couple weeks. That's my experience with it, at least. Okay. So that initial, immune response of 72 hours. The problem here is the inflammatory substrates around that nerve root. They don't really have anywhere to go. That's why epidurals are a thing. Oral steroids and anti-inflammatories can be helpful, but sometimes you just got to get really specific with it and just get them away from that nerve root. All right. All the cytokines and substance Ps and all the really acidic metabolites, if you guys are familiar with those. So yeah, 1 to 2 weeks, I would say, in my long-winded way.
I can't tell you what a conflict I'm having right now, because I didn't have access to any of this stuff that you're talking about. I don't think that the folks that treated me knew any of what you are saying now, or if they did, they were they did not communicate.
We need names. We need all their names. We just throw them under the bus.
Dr. Leon McGregor.
Yeah, I mean, I could go on for days the way that they kind of treated me, like this woman with hysteria coming in, crying too much.
Okay, well, there's a lot there. So one, yes, there is a huge deficiency in perceptions around females' pain. 100%. That's I think that's pretty well documented in the literature. Unfortunately, that is a thing. So there's that. Two, then you can get into, well, do they know? Do they not know? Do they care? How busy are they? Yeah, there's a lot of barriers to improvement there. But again, that's why I set up the way I practice, the way I have, so that I can be in a private, controlled environment, one-on-one, where I can really make an impact early on. Like early intervention for these things is really key. So yeah, I can't speak specifically to the care or why you got the care you received, but unfortunately, the female aspect is a pretty big issue
Yeah.
in healthcare, as I'm sure you've experienced.
Yeah, but what I want to highlight here, though, is that for anyone who's listening to this, who either has folks in their lives or one day may experience, I mean, this is not something I ever expected to experience in my life. It just happened that what you're sharing, especially with the initial interventions being within very close to the time of injury, I think to have the care of someone like you by my side would have made a huge difference in my trajectory. Like I said, I truly do have post traumatic stress from what happened.
Yeah.
And part of it was the dismissiveness. So
Yeah. I have never, knock on wood, had nerve pain in my back, but obviously I see it on a daily basis. I can't. This would be an interesting topic to talk about at some point. I can't truly empathize with what that feels like, but I can recognize it, if that makes sense. And nerve pain is just like this unrelenting, always there. It's like a cloud that's every movement, every thought you have. It's like you have this subtext of nerve pain, which is usually sharp and burning. And then if you have that as you experienced, you're dealing with this massive physical, mental, emotional frustration, and then you have a provider who's somebody you're supposed to go to and trust and is there to help you. That's like, well, what did you do? Did you do something wrong? Or like, oh, you're saying your pain's a 10 out of 10? That can't be right.
right.
That's the most level of pain.
Yeah.
Yeah. So I don't know. I don't know what to tell you. It's
No,
bad care.
totally no.
You got bad care.
I'm having a moment of like um, joy for the fact that someone like you exists now.
Yeah.
And I will say,
I'm not the end all be all of spine care, right? I think I'm pretty damn good at it, but I don't think there's one best method. I don't think there's one school of thought. I don't think there's one person or practice or place that you need to go to. I think just if people had a better understanding of all of the aspects that surround it, we would all be much better off. Yeah.
So what would you change? Like if you could change something for the general public, right? Like you could just wave a wand and X knowledge would be distributed. Even like what would be the key things you would want everybody to know about how their spine works in order to keep it healthy or keep it pain free?
Understand that it is a bridge to transfer force. And okay, let's table this for a second. I am coming from a purely biomechanical, musculoskeletal, like this moves that, right? Obviously, the spine serves a number of other functions in the different physiologic systems. But I would say understand that it is a bridge, and we want to be able to control the stiffness of said bridge in different ways. Now, I could elaborate on that for days, but I think if I had to boil it down to an elevator pitch, that's what I would say.
Okay. And
does that make sense? What I'm saying?
It makes sense to me. I still feel it would be helpful if we kind of keep picking it apart a little bit. So, are there particular? So, let me put it this way. Let's say, what does having that understanding mean? So, for example, I have an understanding that it's a bridge and it's transferring energy, and we're trying to maintain some level of sort of rigidity and stiffness in that core. What would that look like now that I have that understanding? Like, is there a set number of a certain number of or type of exercises, or is it sort of more broad, like how I sleep and how I move just in general, how I'm walking every day? I mean, walk me through that a little bit if you don't mind. I know it's a bit broad, but
No, well, yes, it is a bit broad, and there's very broad answers. So let's see, where should I start with that one? I would say the main driver is making the mind muscle connection so that you know what it feels like to have engagement or good engagement of your core. And I do the little finger wag because none of us can even agree on what the core is. When I'm telling you about the core, that's Adam's understanding of the core. I think most would agree with me, but we'll table that for now. So you understanding what that feels like so that you can replicate that, you can build up those pathways. And then if you do that enough, we know that motor learning is a thing. It becomes more reflexive, and then you don't have to think about it. The abdominal brace, which is what we're going to refer to it as when we're engaging all of those muscle tissues at the same time, that is really the underlying tensioning system that you should feel with most, if not all, abdominal or core exercises. So once you understand what that feels like and how to turn it on and off, because inhibiting a muscle is actually the higher level of control of muscle tissue, that's really what drives it. There's no there's very strong data that would suggest that after you have recovered to within normal limits from a back injury, there is no real difference between any sort of exercise modalities. Pilates seems to sometimes edge out and when you're looking at everything, but it doesn't seem to matter if you're doing core specific stuff or just general exercise. Once you've gotten your core under your control, you can do anything. It's just movement, right? So I hope I'm answering your question. It's kind of the creating that mind muscle connection with all the tissues around your core.
Yeah, definitely answering my question. So what would step one look like for me? Let's say I want to learn how to make that mind muscle connection specific to the lumbar spine. Let's keep it relevant to the same example.
Yeah, so go ahead and schedule an appointment with me and give me your credit card and we can So abdominal brace, the way I teach, well, I'll tell you the way that I was taught this to educate patients, and then the way I do it now. The way I was taught was you direct patients to lay on your back in a hook lying position, so your knees bent up, and then we want you to draw your belly button in toward your spine and then scoop it up under your rib cage. Go ahead and try to do that and see if that makes any sort of sense to you.
I'm still trying to visualize that. Okay.
Yeah,
so
then
lying on my back, legs are my shins parallel to the bed?
Feet are on the floor, so like a pillow under your knees, for example. Yeah.
Okay. So feet are on the floor.
Yeah,
you're on your back, your knees are bent up, feet on the floor.
Okay. So I'm laying down on the floor. I don't know why I was on an exam table, and that's okay. Yeah. Okay. Feet on the floor, and then now I want to take my belly button and try and suck it back towards my spine, and then up towards my ribs.
Yep.
Is that?
Yep.
Okay. All right. I can visualize that. Yeah.
Okay. So now try to do that 6 hours later when you're at home trying to do your PT exercises on your own by just a little shitty little picture from I won't call out any of the exercise programs. So anyways, that doesn't make sense to most people. And not only that, it's not reproducible. People mess this up all the time because it doesn't make sense, right? So what I do is I remove as many barriers as possible. How can I get people to engage this make it foolproof, right? So same position, I put some sort of weight on their lower abdomen, usually like a little medicine ball, 8-pound medicine ball or something. You can use your hands or textbook or something. And all I tell them to do is, without lifting your butt up or arching your spine or anything, use your stomach to push that weight up towards the ceiling, as high as you can push that weight up. So can you imagine that?
I mean, I'm just imagining sticking my belly out. Is that correct? Okay.
Yep. So for you to be able to move that weight up towards the ceiling, you have to increase the intra-abdominal pressure, which means you have to engage all of those muscles. Now, usually people have a deficiency on turning on the muscles on the backside, the posterior tissue. Everybody's nice and strong on the front because of all of our sit-ups and crunches, right? And look in the mirror and flexing. Is that just me? That might just be me. But the back side is the tough side. Yeah. So what you'll feel, you can take your hand, make a C, dig it into your spine in between your hips and your rib cage, push down, and then you can feel those tissues tighten underneath your finger. But the backside, you have to push it as hard as you can to start to feel those muscles click on. If you're untrained, if you're trained, it'll happen a lot faster. But that's it. I have them do 10 or 20 or 30. And to be honest with you, that's usually the only thing I send somebody home with on day one, because that is, if we don't build our good base on what everything else is based off of, then we have a very low chance of being successful. So abdominal brace is what I refer to that as. And yeah, lay on your back, knees bent up, feet flat on the floor, put some sort of weight on your lower stomach. Use your stomach to push that weight up towards the ceiling, hold for 2 seconds, relax back down, and just repeat that. It takes about 10,000 reps on average to start ingraining the synaptic channels for a motor pattern. Think like throwing a baseball or something. No, do not go home and do 10,000 of those, but I do tell people, just to give them a sense of, we want this to be more reflexive. We want you to be able to engage that muscle activation without having to really think about it. Does that make sense?
Yes. Thank you.
Are you lying just so I look better?
No, I'm lying so that I look better.
You still can't picture the position, can you?
No, I can't.
You've never laid on your back.
No, I don't sleep.
Vampire. I knew you were a vampire.
I sleep in the coffin standing. I just look old, but I'm
not touching that.
Yeah. So, all right. So you've taught somebody this, they've done, let's say, not the 10,000, but now they're definitely comfortable with it. What would next step look like for that person?
So now you just start building around it. So one, you have your good thorough assessment to see if you can recognize any deficiencies in movement or range of motion or strength. So you've got that in the back of your mind, right? You might have a lateral hip muscle weakness or something on one side. I don't know. So you want to make sure you're addressing those, but essentially you're just building around that. You're making those movements harder, right? The abdominal brace movements, which is adding arm or leg movements or changing the position or adding weights. And then you just build it out from there. So that's what I consider phase 2, is the individual tissue deficits that we're addressing. And then phase 3 is function, right? Getting people back to doing more functional movement, like a squat or transitional movements or playing a sport or whatever the case may be. So you're just building out around it. But because that's such a base movement, it's really, really important to me and my patients that they are comfortable with that. They can do that without me monitoring them, so that they can reproduce this correctly at home, and that they know why they're doing it. Another important piece of this to remember is, when you start adding movements, you remember what I said, inhibiting the muscle is the higher level of control of neuromuscular activations. So you want to engage the muscle, the abdominal brace, do whatever movement, and then you want to relax completely, right? We are sending those electrical signals from the brain down to the muscles and back up every time we activate and inhibit. If you just tense your stomach and do like 30 leg lifts, you're really only doing 1 rep of what we're really trying to achieve, which is linking up your brain to that movement pattern or those muscles. Clear as mud?
Yes.
Yeah. No, that makes a lot of sense. I'm going to turn it around a little bit. So earlier you said, like, this is how I was taught, but that doesn't make sense, so I do it this way. Kind of in a similar vein, what exercises or movements do you see either being recommended or just folks doing because maybe something they saw online? Like, what are some things that you just look at and go, this is just a lot of movement and it's doing nothing, or it's just useless? Is there anything like that?
Not off the top of my head. It can all be good, and it can all be bad, depending on the person and the time point and the situation. I don't know. Do you have like an example of something?
I was like the image that was going through my head is, like somebody warming up before a sport, and then maybe you're looking and quietly going, "Well, that doesn't do anything," or that doesn't, the guy's doing static stretching, you need to warm up first, and things of that nature. Like, what are some common pitfalls that some of us might be kind of running into with lack of knowledge? I mean, going back to your point of, if you could, you would educate as many people as you could.
Yeah, I think it's more about what is your goal in that session or that activity or that sport that you're like. What are you trying to get out of that movement? Are you trying to attach 80 different bands and do 20 different movements? Well, why? As long as you have a why, then I'm good with it.
Okay.
Yeah, that's the only answer I'm going to go with you, because there's no good or bad exercise. It's just what is better or what is not as effective at this time point for this particular body.
That makes sense.
Sorry, it's not black and white for you,
No,
Dr. Vahid.
trust me, we all live in the world of
I know you're
gray
terrified of
area,
nuance.
and yeah, that's my word of the decade, by the way, nuance. I think I say it so much it annoys some people.
Not
Yeah,
me.
but yeah, answered like a true scientist.
Yeah. Yeah.
Pega, does any of this?
I want to hear more about Pega's
Yeah,
experience. I think
yeah,
it'd be really helpful for people to hear the patient side of thing, and I think it would be even more helpful for other providers, namely physical therapists or any conservative specialists, to hear the patient side.
Yeah, I think what I will say is that I don't know. I want to make sure I'm not saying that the entire medical community sucked. I actually would love to just like send a shout out to my surgeon if he ever is listening. His name is Christopher Tamaris. I think he's part of Polaris Neurosurgery. I think their name changed since I went through, and he was wonderful and like took one look at me, and I had gone to him later. Like I said, the timeline was much later. So by the time I got to him, I was pretty bad off. And he just nailed it, said, it's time for surgery. And I think others were sort of trying to kind of throw darts at a board, see what stuck, but no one really knew what to do. And I think it just happened to be when I came along and what was available, really. I think different people tried. I had one PT, I can't remember her name. She was lovely, and there were things that were very hard that I did, trying to strengthen that core and stuff that you talked about. That like I can recall doing a couple of exercises where I was like, "Whoa!" To notice how weak I am in that area or how unbalanced I was in that area, gave me a lot of information. But what really became important for me was that this was a necessary evil. Like, and I get what you're saying, Adam. I can feel it in my body that there's something off about my left side versus my right side. I mean, it can't not be, right? Somebody went in and shaved part of my body off. And I will have to manage that for the rest of my life. I think that the thing that's really important to me now is, and what I was hoping to get across to listeners now is, that sometimes this just happens, right? We don't have all the information that we need to say, okay, prevention. But some of it is, yes, hydrating. I had no idea. And taking care of one's body in the ways that we all talk about. Yes, I agree. So there's the prevention, but for me, it's, I guess you would call it a postvention. I don't know if that's a word, but that's kind of where I am in my life, where my spine and my spinal health is always like a kind of like a compass or a litmus test for how I'm doing. When I start to have those residual nerve pain down my leg, it's a reminder to me of maybe what do I need to do again. My favorite little phrase is, reassess, readjust, and recommit. I'm doing that all the time when it comes to my back. If I start to feel something and I'm going, okay, I think I did a lot of moving, for example, like I mentioned before, this past couple of weeks has been a lot of moving. I'm surprised I haven't had that kind of residual pain I usually do get. I think I mentioned the Mackenzie method that came along after I had gotten surgery. It was around before, but not a lot of information. I was just sort of digging on the internet, couldn't find anything. Now there are YouTube videos that show, it's kind of like what is it called, Adam?
The prone press up progression.
Yeah, since I do so much yoga, it's also called like a Sphinx pose in yoga. Like,
yeah, I'm bad with the yoga names, but yeah.
Yeah, you just push up against the ground like this, and you just hold. And the difference between this and yoga is that you really relax the back, like you were saying, the intentional. What did you call it? The inhibiting.
Yeah.
So really, really, really relaxing the back, and all the muscles, so that from what I heard was to push the jelly donut back in, um, because it'll have a tendency of wanting to pop out again because it's already been weakened.
Yeah, and most of humanity will have some sort of disc bulge or herniation in their lifetime, and most of those will just reabsorb on their own, give it enough time. So very painful, very uncomfortable. Time heals most, if not all. But we got to remember that too. Like the body is very, very powerful. And the problem comes when people start to exacerbate or re-injure it, right? Every time those tissues get a little weaker, and then it becomes a little more easier to herniate or bulge or whatever term you want to use for that. I do want to say the surgical side of things is not shouldn't be looked at as good or evil. I mean, they're great interventions. It's just as with everything else, we are in a constant state of flux. So I wish people would go into surgery understanding you're not going back to what you were. You will be different, right? In whatever capacity. And as long as you understand that difference and how to manage that, people, you'll be great. There'll be no problems. But it's the people that just expect to do the same thing and have different results. I think there's a term for that. That they don't have good long-term outcomes. Yeah.
And I can say, there's this concept in psychotherapy world called the post-traumatic growth. It's a really beautiful concept in that, one of the things that this offered me, even though, of course I teared up. I think that's like what, 3 out of all the sessions we've ever had together. Yeah, is that it was extremely beneficial in helping me to connect with myself and prioritize my well-being, because I basically had to at that point. My body became, rather than it being an afterthought, it became a priority. I know that's really silly to say.
It's not. It's not silly.
No,
I think
it's not going to let you ignore it for long.
Yeah, I was gonna say that can apply to so many things across our body systems. That your body will usually give you signals, and if you ignore them, they'll get louder and louder, and there will come a point where you can't, like Adam said, you can't ignore it. Right? I feel like most people have an experience that kind of parallels that. I know I do. Obviously, you do. I'm sure Adam does. It is not silly at all. I think it is just the way it is. Yeah.
Yeah, it really is. This is what I mean by when I get that pain, or when I'm recognizing that maybe I'm falling off, I recommit, and I have a reason to recommit because I know the alternative. And it's been really helpful in my relationship with my body, and my understanding of what my body needs. And it sort of is full circle for me.
Yeah, I'm glad you're making a conscious effort to perceive it like that, because that's really important in the long term. I mean, you basically have a superpower. You have another lever that your body can pull to make you aware that something might not be right.
Yes.
And that's a good thing, in my opinion.
I agree.
Adam, do you have just kind of, I know we might have to do a little bit of digging, but just in case you may know any kind of data on decompression type methods. So I know different practitioners more in the chiropractic world will recommend things like spinal decompression. Can you tell me a bit about that? How much of that is evidence based, if any of it, and evidence based for what? For short term sort of pain relief versus long term benefit? Like anything you could share about that would be helpful for me.
Sure. I probably can't recall all of the specific evidence, but first I'll say that musculoskeletal research is hard because we have this thing called the IRB, right, Institutional Review Board, and we basically have to be ethical. So that means we can't just be biopsying people's tissue whenever we feel like it. Like, do this set of bicep curls and let me take a chunk out of your biceps so I can look at it under a microscope. So really challenging to do musculoskeletal research, in my opinion. With that being said, it's kind of all over the place. It depends, again, what the underlying cause is. I'm going to go to discs first, and then we can talk about nerve roots. Discs definitely function like a sponge, for lack of a better analogy. It has excess moisture when you release the pressure. For example, when you're lying down or when you're sleeping. That's why we're a little bit taller when we wake up in the mornings, or your disc or nerve root pain might be a little bit worse in the mornings because fluid has been pulled back into the discs. They've gotten thicker. And then if there's any sort of pressure issue, it means it's going to be putting more pressure on that. And then when you get up and move around, you got gravity pulling the weight of your body down, and it's pushing the excess fluid out. So that's the main way by which our discs hydrate themselves. And that's also the main way that the vascular system with the end plates of the spine bones, the vertebral bodies, and the discs perfuse themselves. So it's kind of like a compression decompression. So we know that that's a thing, right? So logically, you might say, okay, well, if I decompress it, then that's going to help. And maybe that's the case. We've certainly see it help people. We've certainly seen it not do anything. I don't know what the overall body of literature would say on it, but I would be hesitant to make note of that anyways, just because of how challenging that would actually be to assess properly. Like, everything's questionnaire based and pain score based, and that's a whole slew of other issues. But theoretically in the lab, yeah, compression and decompression would help to pull fluid in and out, which would help tissues to breathe and perfuse and heal. I don't use it too much in my practice personally. I think there's better uses of time. I don't think it's terribly risky as long as you're asking a couple safety questions, make sure you're ruling out any red and yellow flag type of contraindications. But that's, I look at interventions on the risk benefit spectrum, right? Is there a lot of risk to this? No. Okay, well, go for it. If it's not wasting a ton of my time and your time, it's easy to do, there's not a huge financial burden, and not a huge risk, then sure, go for it. There's plenty of people that have gotten some relief, even if it's just literally pulling space apart so it's not pushing directly on the disc or the nerve root. So I have seen traction or decompression, or whatever you want to call it, work a little bit better for really acute nerve root inflammatory conditions, but it's very short-lived. Treatment effect time is something of important to note here, right? The second you stand up or you've got gravity rearing its ugly head on you, it's just going to be placed right back into position. So in my opinion, I don't think it's terribly helpful for me as a provider, but as a lay person, yeah, go for it. Does that help?
Yeah, no, that was very insightful.
I know that's a very non-committal answer.
I started
I don't want the traction bros to murder me, the decompression mafia.
Yeah, well, hey, it's a good thing I didn't ask you about cracking, back cracking, all that, and I won't because I don't want to offend anybody. But you made me sort of visualize an accordion. Would that be a good way to think about it? You know how like the accordion, when you're pulling and pushing, it kind of made me think about that a little bit.
I mean, I don't know why you can't accept my sponge analogy, because that's much better than the accordion, but sure.
I'm more musical. I don't know.
Oh, okay. Okay. Shots fired, sir.
It says me to the musician, by the way, right?
Yeah. Well, I will say quickly, decompression. I'm going to throw this out there too, because I would feel bad if I didn't say it. I definitely see really high tech devices in the hundreds of thousands that people utilize and say that they can directly target L4, L5 on your left side because of these physics and mechanisms. I'm calling hard bullshit on all of that. Don't waste your money on that. Get a little contraption at home or a little Saunders home traction unit. You don't need to be spending money on traction. How about that? That's my stance.
I appreciate that a lot. As someone who was in so much pain and so desperate for anything that could help, I did spend over $1,000 once in one specific store that promised me all of these things and I was just like, I'll go home with all of it. But
I wish that your story was unique. I think that that's pretty commonplace. My very, very close friend and your good friend had a neck situation. And I think during all of those months where he basically didn't sleep because of the pain, he probably spent thousands on different pillows and different mattresses and different devices and different chairs, all promising to get rid of the pain. And that's the thing, when you're in that vulnerable state and you are in so much excruciating pain, you'll do whatever. Like, I will sign a deal with the devil just to make this go away, right? And so I think that you make a really, really important point, Adam. I think that we do have an ethical responsibility, all of those of us that are within healthcare, because we are receiving folks in a vulnerable state. Obviously, intense nerve pain is, not the same as other types of pains or illnesses, but it's all vulnerable, right? That's somebody who's not doing great, that can be taken advantage of. And I think that's why ethics should be so sort of like the top of mind anytime we see anyone. So really, really good point. I'm glad you brought that up. That happens way too often. Unfortunately, people get taken advantage of.
Yeah, always always check in with your provider on what is our plan of care? What are our goals? Where are we along that continuum? How are you assessing that? Are we moving in the right direction or not? Because I see people get sucked into these providers that make them dependent on them, and there's no real plan for progression, right? My goal is to never see you again. I wish that would work on YouTube, but that's not the case. But that is my goal as a physical therapist. I want to get you moving well, and then I want to never see you again. Rather than why don't we buy this package for twice a week for infinity? I'll just leave it there. You guys can connect the dots.
Yeah,
I really appreciate that, Adam. I believe in that in my own practice too, is that if I do a really good job and they get better and they go on with their lives, then that's just good karma for me. And I think the best type of marketing is word of mouth anyway. So
no, I have to disagree. I get paid so much by the pharmaceutical companies. Every time I prescribe a statin, I get $1,000 cha-ching in my account, or any medication I prescribe, I immediately get paid tons of millions of dollars.
The lizard people are. I do want to throw it out there real quick though, because it is weird though, especially the three of us have our own businesses, right? And our business is healthcare. So it's always an interesting line to try to walk. And that's why I'm always like, maybe I'm more sensitive about it, but I'm always possibly over explaining what's going on and where we're at, because I never want people to feel like I'm just abusing their trust in any sort of way. But there certainly is a interesting conundrum in, okay, I need to help this person, but there's also such a thing as patient churn. And where's the next patient coming from? Well, I would hope that if I have good outcomes, the rest will take care of itself. And I think it does. But there's lots of people who don't feel that way. We'll leave it there.
That'd actually be a good conversation to have in general. I think that we're at a time right now more than ever where that's a conversation being had with or without us, right? A lot of folks are thinking about the business of healthcare and trust in the system. And so I think that would be a good conversation to have. Awesome, guys. Well, thank you, Pega, for sharing. Thank you, Adam, for your expertise, your knowledge. That was very insightful for me. I'm hoping anybody listening probably shared my opinion on that. And I guess we'll keep it going next time.
Yeah, next time we'll quiz Vahid on what the hook lying position is and see if he has any.
Am I gonna have to do the next one lying down?
Carryover.
But yeah, I feel like with spine, we've got so much we can tackle, and depending on the level of the spine and all kinds of stuff. So I'm excited to talk more about that.
Cool.
I got my questions answered. If you guys are good, I'm good to go home a little early today.
Always a pleasure.
Take care.
Bye.
Bye.
Thanks for spending some time with us today on Take 3 and Call Me in the Morning. We hope today's conversation gave you something to think about. If you enjoyed the episode, consider subscribing, leaving a review, or just sharing it with someone who you think would appreciate it. If you want to learn more about us and our individual practices, you can check out Pega's practice on her website, livingfullytherapy.com. If you're interested in Adam's physical therapy practice, you can learn more about his practice on his website, equalizerhealth.com. And if you want to know more about my practice, you can go ahead and check us out at healthyconditions.com. Just a quick reminder before we go, remember this podcast is for informational purposes only, not intended as medical advice. So please talk to your healthcare provider about what's right for you. Until next time, and don't forget, be kind to yourself.